Okay, hopefully there's a few people joining us here. I am with Dr. Nick Studdert, and Mel Logan. We've got a podiatric surgeon. I'm Ken Hungerford, podiatric surgeon, and we've got an exercise physiotherapist ready to go with us. Sports and exercise physio, APA titled. Let's go the whole title here. We're going to be talking a bit about pain and assessment during today's sort of forum, and we're going to sort of delve a little bit more into that difference between sort of a podiatric surgery and a physio approach to pain, because there's a lot in it. And, we've been talking a bit about pain today. We've been talking a bit about assessment. And, I know that Nick and I see a lot of pain, but we're going to ask Mel what sort of pain she's seen and how she deals with that separately as well. Of course, if there are any questions, throw them in the chat. Dave's behind here going to be giving us a bit of a yell and let us know what we're looking at. But let's see what we can get through today, because initially I want to sort of have a bit of a chat about how I manage pain. And I know Mel is very local to us. She's about two clinics down. And so we have a bit of a chat quickly in the corridor as we're running in and out of our busy lives. But, I don't know, I want to hear a bit more about sort of how she works and, where Nick's interests lie as well, and going from there too. And so whereas I do a lot of laser therapies, injection therapies, and a few other different things, whereas physio is a lot more sort of hands and mobilisation sort of base. Tell me a little bit about that, and let's get this conversation going. So what are you typically doing for your pain management patients at the moment, or someone that comes in with a pain, whether that's a sprain or strain, and go from there?
So I guess as a physio, we do deal with both acute and chronic pain a lot of the time, and how you would apply different treatment techniques is going to differ depending on who's walking through your door. Is it an acute ankle sprain where you've got a lot of swelling, they can't weight bear? That's when we probably do more like manual therapy, maybe some gentle mobilisations, plus some gentle exercise to get them going. Whereas with the chronic pain people, sometimes they can be very fear avoidant. So you have to be gentle with those guys. And yes, we'll still do some manual therapy, whether that's a bit of soft tissue work or maybe some dry needling or something like that, just to build their confidence and get them moving again. And then we kind of trick them into being like, oh, okay, it's safe to move. So let's get you on an exercise program that's going to benefit you, and then hopefully, rewire those chronic pain pathways that we kind of see coming through the door as well.
Yeah, and that's it. It's really about getting people moving. And like you say, it is almost tricking them into it. One of my favourite ways around this is actually using hyperfix tape and just taping up their arch, just so they've got that proprioceptive feedback as well, building into there. And that's going to just rewire sort of how the brain perceives sensation, and, that hyperalgesia as well. And I know, Nick, you were talking a little bit more from a nerve and chronic pain sort of perspective earlier as well. Yeah. And then we were talking a little bit with Dr. Chow there on some of the aspects that he was covering. And, we're really excited that it was really covering off, and, we were sort of, moving hand in glove type of thing into the different presentations that way too. Yeah. Tell me a little bit more about sort of how you were perceiving that too, Nick.
Well, so I think it's sort of important to point out that often we can get distracted by the underlying pathology that's causing the pain. For the patient themselves, often the pain is the thing that has brought them in. The pain is what they want dealt with. In those chronic cases, it's the pain that's impacting their lives. And in order to implement, as you were saying, Mel, certain treatment protocols, you have to deal with that pain to begin with. So if we simply look at the pain as a symptom, we're not going to put anything in place to deal with, or we might be limited in what we can put in place to deal with those underlying things, because we're barred from it. So approaching pain as the first step, putting in those adjunctive therapies that can offload the pain, give them the confidence, allow them to access the longer term plan, is a first step that shouldn't be underestimated. And what Dr. Chow was talking about, and what I brought up in my presentation, was that often these things can be a little bit time consuming, because we have to talk to the patient more, we have to assess the patient more, and that may not even simply be in that initial appointment, but it might be in ongoing appointments. So paying attention to it is worthwhile because it has an outcome for the patient. Once you establish that that's where they're getting stuck, again, you can put those adjunctive therapies in and give them a road to recovery, which I think is what they were initially looking for.
Yeah, and I think, there's so many different ways to go about that. And, Mel sort of touched on a few different things that I'm like, oh yeah, dry needling is really effective. And it's something that I don't use as much, and definitely rely on my physio colleagues around that as well. But it's something that can be underestimated as well. And is it, as part of that comprehensive plan, it's really putting as much into place as possible. And I think, where do you, Mel, sort of see, obviously we're thinking quite complex, and, we've taken a bit of a take for sort of the chronic pain, and, there's quite a lot going on in that sphere as well, from that biopsychosocial as well as the actual physical trauma. But for you, when you see someone come in the room and you're starting to assess them, where do you start thinking, okay, is this acute, is this chronic? Obviously time's a big part of that as well. But sort of what treatments or interventions sort of say, for me, burning pain, I start thinking straight away I'm going to go more likely for an injection therapy. That's sort of my okay, this is a little bit deeper. Is there something like that when it comes to pain for yourself that you're like, okay, this is the track that I want to take? Or
I think similar to you guys, like we always flag for how they describe their pain, the different types of pain that we're dealing with. I think sometimes with your more chronic pain patients, you have to be a little bit more gentle and a little bit more cautious with them. And like some people might not be up for dry needling, and that's okay, because if they're like very like sensitized, and like say if we're dealing with like a sciatic nerve problem or something, and that nerve is just firing away, and they can't walk, and like I'm not gonna try and do probably too much manual therapy with them too early on, because then we're at risk of, I guess, making them a little bit worse and firing everything off. And so it's a bit of a balancing act, and I guess it's a fine line between how much manual therapy do you do when it comes to chronic pain. I know a lot of physios can be completely hands-off in the chronic pain kind of sphere. That's probably not my kind of background.
It's not your jam.
No, so I'm going to say that now. But like, because I deal with a lot of acute sporty stuff, but that doesn't say that I still see a lot of back pain in my clinic, like chronic rotator cuff tears. And I think sometimes the hard thing is, like, is this an acute episode on a chronic injury, or has something else developed because of this chronic injury? Like sometimes that is what we're dealing with as well. So I kind of say to my patients, well, let's just try and get maybe the acute stuff sorted, or these changes that you're feeling now sorted. And then once we get you back to your normal, then we'll kind of come up with a bit of a plan and go from there. And I guess just try and get them more active with some self-management strategies and exercise and just being as active as possible.
Yeah, and that's it, hardly ever does someone come in and say, I've got pain right here and that's my only problem. And we talk about this a lot, and it's like, okay, well, let's see what's this, potentially acute on chronic. Let's start delving into there. Let's give some diagnoses out, 1, 2, 4, 5, 6, and then start managing those as part of that comprehensive plan. And I think it's really, and I'm a big one for that patient expectation management, and particularly surgically, like I said in one of my earlier presentations, a lot of patients finish up surgery in pain. And, although they may have been in 8 out of 10 pain, they still may be disappointed if they come back even in 2 or 3 out of 10 pain. But, we've come a long way. And I know Nick and I have been working together for a couple of years now. And yeah, I think it's, it's a really big part there of, and that initial diagnosis and then managing it.
I do think that the pain can mask those things, complicate it, and muddy the waters often. And that's not just for us as clinicians, but we have to think about for the patient themselves. So the pain can be overwhelming, it can be non-specific, it can be constant. We see it for a very short period. We assess it for a very short period. But they're living with it often throughout the day, overnight. It's affecting other aspects of their life. And so as clinicians, it's our job to empower the patient to deliver the right information to us, give them the ability to deal with that pain so that we can address the underlying pathology. It's a really tricky area, but it's an area that demands attention, because if we don't do that, our cells fall into these treatment cycles where we never quite bust the patient out of that. And we've probably all experienced this, where at some point the patient wanders off because they're not having an outcome. And very often for mine, it's because they're not only not having an outcome objectively, but for them themselves, they're not getting what they want out of the treatment. And it very often revolves around their level of pain. Is it a 2 out of 5 or whatever? So.
Yeah, and I think, we talk about that patient-centred care and multidisciplinary practice of bringing everyone in. But sometimes we forget, okay, well, what's the patient's goal? What's their expectations around that? And making sure that we're really right there. And I think Nick touched on a really important part there as well. And, looking at their pain and what's important, but, assessing and keeping up. And I know one of the professors through UWA, and, his first thing was always palpate, palpate, palpate. And, I know myself, sometimes I, forget to palpate, the other foot, for instance. And the patient is all about their left foot. And it's like, well, let's actually compare this. What's happening for the right foot? Let's make sure we're not missing anything. And sometimes, and we've all been there, I hope, that on the second session or after the first session, most importantly, is you go, oh, I really should have checked X, Y, and Z. I need to do that extra assessment, or, let's schedule them in for more of a comprehensive, and in podiatry we call it more of a comprehensive biomechanical assessment, and really delve deeper into, okay, well, how are things functioning and why are they functioning, and going a little bit further. And, definitely during our undergraduate podiatry degrees, it's all about the windlass mechanism. It's that big toe mechanism, and if you don't have that, then you're going to be propelling through your jaw, and people are going to be seeing their dentist because of that. And, when really an orthotic's going to fix everything. It's not as simplistic as that, but it is definitely something that you start thinking, okay, well, what assessments are pretty critical? And, let's take it a little bit further away from the foot and ankle, because I know, although we have a few podiatrists on board at the moment, let's start talking about sort of hip and lower back, because, particularly when it comes to paediatrics, Mel, I am definitely looking for that developmental hip dysplasia and those type of things as well, and leg length differences. But what sort of assessments do you start looking at when someone's coming in and they might have hip pain? Because this is something in podiatry that, we don't do as much on. It's really in that postgraduate sphere that we have to learn a lot of this. Is there anything in particular that you might be able to add as far as, do not miss type of assessments?
I think the lower back and the hip is a bit of a grey area in general. So because I guess so many things can refer from different areas, it's not very straightforward. And a lot of the time when my patient will come in for an initial assessment, I'll explain to them, like, it could be this, this, or this. Like, I'm a little bit unsure at the moment. Let's treat this, see how we go. You'll come back in. I'm hoping you'll be better, and then we'll be able to, nut this out a little bit more. So I guess with physio, we do have what we call our special tests, and they are supposed to help us diagnose. And most of the time, they are good. There are some better hip ones, which I can be sure if if I do a fatigue test where I'm really loading up the hip joint, I know if they're getting pain on that test, then I'm 99% sure that they've got hip joint pathology there. So we do have those tests that are have quite a high success rate, whereas there's other tests that aren't so much. And I think as a practitioner, you just build on your skill set, and as you see more people and you see different bodies, and you build on those that more clinical experience rather than relying on specific tests as well. But yeah, the back and the hip is pretty tricky. A lot of people do present, especially kind of middle-aged women is a common group that I see, where they'll have kind of back pain with hip pain. So whether we're dealing with just some non-specific lower back pain, or it could be coming from their SIJ. We could be dealing with some trochanteric bursitis, or a deep glute tendon problem. Kind of what you were saying before, Ken. It's nothing in like the real life is straightforward. So I think at uni, you used to get a case study and it'd be like, they have pain here. Whereas in real life, they have pain in 3 different spots. So, and I think, like I said, as you improve as a clinician, you become more confident in seeing things and knowing like, oh, well, if they're describing that I get pain sleeping at night on my left side, I might be thinking more like hip joint pathology or bursa and things like that. Whereas if they're getting pain maybe coming like in and out of the car when they're moving into flexion, then I might be thinking more hip osteoarthritis. So, it's a bit of a tricky area, and I think it can take a little bit of time, like what you guys were saying before. So, yeah, and I like being honest as a clinician and telling my patients, I'm like, I'm going to let you know that if I'm a little bit unsure of things, I'm going to tell them that, and I think they appreciate me being honest with them instead of trying to guess and wing it and see what happens. So
that's it. There's so much to pull apart there.
I think Mel just hit on something really interesting, and really important, which is functional assessment. Talking to the patient beyond us examining them on the table in that artificial environment, talking to them about what activities in their life they are or are not able to do, when is the pain the worst, is really important. And the thing that sort of typifies that from a podiatry point of view is a gait analysis. So making sure that we're doing a gait analysis in the context of enough distance to get natural gait, and remembering that a proper gait analysis starts from the top of the head all the way down to the feet, looking at the positioning of the upper body, looking at how everything moves together while they're functioning. I know that you're big into running. If you can observe the patient running, even if it is just on a treadmill, that gives us more information about how those central structures that are so important to that sort of full activity, full function, are actually causing pain or manifesting in particular symptoms. So.
Yeah, and I think, it's a real shame that these two were in different rooms during Mel's chat just then, because Mel was like, yeah, all onto this, and it's so good. We've had this a few times. It's like we've coordinated our speakers really well for this, and that was definitely on purpose, I swear. Definitely. We're having this, it's a common theme, obviously. But obviously something is happening there, and, having that conversation with our patients, when is it happening, like Nick said, like Mel said, but, those common clinical scenarios that we're seeing, and it does take experience and a lot of experience at times, but it's once you start putting those pictures together, you start going to the patient and how many times do we all sort of get to the point where we are assessing, and from our subjective information we're like, okay, it's either X or Y because A, B, C, D, E, F, G have already been ruled out. And I think that's a really powerful thing. And, whether it is, aching at night or, whether it's first steps of the morning, we're quickly being able to assess whether that's actually, potentially bone or potentially muscular fascial in origin. And I think really delving deeper into that with our patients is really important. But, you also said there, Mel, that some of these assessments, and I think it's really good. And my first thought was around, it's diagnosis by exclusion in so many things. And it's great. We've got these really sensitive tests that are going to, potentially rule out hip osteoarthritis or trochanteric bursitis, I think it was. And it's just great. Okay, let's do these and let's get rid of that as potential diagnoses. What are we left with? Okay, X, Y, Z, beautiful. Let's put something into place that's going to strengthen that whole area, take the load off that whole area. Let's look at you walking and maybe do a little bit of gait retraining potentially, but also let's release some of these structures through some of our manual therapies too. Now, whether our pain is X, Y, or Z, it's going to help them overall. And I think, putting that patient back into an anatomical normal, dare we say, is going to be a really good point there. Yeah, no, well, that's it. What's normal these days? Because I think we're looking at a few different case studies overall that are really quite out there and different there. Now, anyone have anything further to mention on that? Because I want to get some further ideas from Nick on how he approaches pain a little bit differently to myself. Because Nick and I actually were working together at the same practice at one stage, maybe 4 years ago.
It was much longer than that.
Let's go with 4 years, maybe 5, maybe 6. Probably is 6 now. And so we're both familiar with laser therapies. We're familiar with a lot of the podiatry core. Nick does a bit of injection therapy sort of stuff. But I want to sort of see his take in contrast on some of these things. I think you know a bit about how I practice as well. What do you see as being different that sort of you're looking at too?
Approach to pain management.
Yeah, that's it.
Yeah, so my approach to pain management is, again, I try to tie it back to exactly where the patient is with it. What do they need to get relief enough that I can treat whatever the underlying cause is? So I'm very encouraging of activity modification at home, drawing on support. I make that a big point to them, that if they have support at home, that they need to use that in order to offset things. At the same time, I'm open with them that sometimes, you are going to be in pain and you will need to continue normal activities and slowly ramp up activity in order to be able to come back from a very painful place. Simple examples like heat packs or hot showers, reminding the patient of those things that they can do to contribute to their outcome. And then from my point of view, I use laser therapy and some of those other adjunctive therapies. I am a little bit more of a proponent of offloading than some people. I do like to give the limb or the foot the space in order to be able to recover, not in a complete immobilization way, in a supportive way. So I'm very big on our simple taping methods. If I need to throw someone into some kind of a temporary support, like a moon boot, I will do that. Even if it's as short a time as 1 week or 2 weeks. Say, for example, we have an Achilles tendinopathy that's just not responding to any of the treatments. It's incredibly painful. The patient's finding it very difficult to do their stretching regime. Give them some time off it for a short period, let them reset, and then come back to it again. Again, trying to break down that pain as a barrier to progressing treatment. So that's usually my go-to approach. And patients, I think, respond very well to it. They like it when you include them in the process. I think we all understand that, being patients from time to time ourselves. And they feel empowered in their treatment, which can help when you get to the more complicated things down the line. So, you could probably sum up by saying that I do believe in throwing everything you have at it to try and get the pain down.
Yeah, and that's a big thing, It's that whole immobilise versus, encourage movement. And at what point do you press that button and say, okay, let's look at this further. Let's stop them and let's go from there. Now we're going to mix it up a little bit more, and we have Dr. Chow that's jumping back in to bring us a little bit more of that biopsychosocial side. And we are going to throw him right through.
Hi, sorry I'm late.
No, all good. Nobody even knew. Surprise entrance.
Hi.
Stage left. We have got this all happening now, right through from pain, physio, podiatry, podiatric surgery, all happening. What we've been having a bit of a chat about is pain and assessment. And we've been talking about, some of our assessments that can really rule out some diagnoses. But I know definitely in pain management, it's a lot of diagnosis through exclusion. And, CRPS being a really powerful example of that one too. And I suppose we're just talking now with Nick is, around that taping and strapping and, trying to modify loading and even, a reduced, a weight-bearing period. But then also, at what point do we put them in the boot? Do we actually completely immobilise? And, when we start going, back into chronic pain conditions, we don't necessarily want to immobilise that. And so I might jump and follow that point straight through. Tell me a little bit more about, what's your thought processes around immobilisation versus, getting people moving?
Yeah. So this has always been a debate, between the surgeons and allied health, and at what point, when the patient has pain for such a long time, whether the patient's, could be a fracture, whether it's been healed, or whether there's a lot of tendon problems, whether they should start moving or not. To give you a strict answer, there's no clear answer over here. Huh?
Isn't that helpful?
I know. But in terms of how we tease out what should be done, what should be not, is that when we look at a chronic pain patient, and then what are the sequences or the complications that result from a chronic pain. Especially for foot injury or chronic foot pain, a lot of problems secondary problems will be weight gain, loss of fitness, all these things. Then there's a question that whether we can rule out that why the reason not mobilize first. If we should start mobilizing in terms of increase in the aerobic or increase of the stretching mobility of the foot, then maybe it's a time that we should make the patient to move a bit more. Of course, when we ask people to move, it's not going to ask them to walk or run for a marathon, right? As a physio, probably a bit more about this. That we're going to be very gentle, greater approach, and how much you can push. In the pain medicine, we also talk about pacing technique, which you probably know a lot about as well, how we desensitize the chronic pain symptoms, and then we'll go from there. Yeah.
Tell us a little bit more about that. What the pacing technique, as far as building them up slowly, sort of. We were talking earlier about almost blindsiding them on it, so that they don't necessarily realise. Okay, well, and correct me if I'm wrong. This is sort of where we're looking at saying, okay, we're going to start something. Realise that it is not causing the pain that they're looking at. Is that where we're going with this, and then building up from there? So tell me a little bit more about sort of the theories and how that actually works.
Yeah. So from chronic pain medicine's purposes, that the pacing technique will be how much a person can do in terms of capacity. Then we normally would learn about scaling it back down about 50% to begin with, and then every could be every week, could be every 3 days, then you increase by 10% of the capacity. One, you retrain the neural circuit and how your body will feel and how much fitness your injury or your pain can tolerate. Then you build the capacity up from it. At one point, this will, of course, come into a limitation of how much a person can do. And also, this will actually introduce the idea of re-strengthening of the muscle fiber of the person to move from there. I mean, do you have any other take on this?
I think in the physio world, there's a couple of Aussie guys, like David Butler and Mosley. Yeah, they do a graded motor imagery, program. So I tend to follow that sometimes. But then it's very tricky, and it has to be patient to patient. And I think recently I had a young girl that ended up going into kind of chronic pain, and we kind of went more of a distraction type technique. So I booted her. That didn't go well. So then I took her out of the boot because we were dealing with kind of chronic ankle sprains. And unfortunately she presented to me about 3 months post initial kind of injury. So I was like, maybe we'll boot this, see how this goes. That didn't work. So then with her, I was getting her to use a TENS machine at night, or she was playing the Wii because she had, hers was a foot issue, and I was just trying to get her to do techniques that were, I guess, distracting her from that pain a little bit to get her more active. And then that actually worked really well for her. So kind of using the Wii at home, or getting her to gently get back in the pool because she liked swimming. So that was a really tricky one, and we got there in the end. It was pretty hard initially because I thought it was going to be a straightforward, mismanaged lateral ankle sprain, and then she went into chronic pain and had decreased sensation through her foot and her shin, and she had some colour changes and stuff like that. So and she's probably the youngest that I've seen with things like that, but that was a great learning experience for me. So it was a bit of trial and error as well. So and
I think that's a really key point. As we're going through our assessments, and we're on a pain and assessment forum here. This is what we're talking about, and it's about doing those correct assessments at the right stage, but also revisiting them. Obviously, in that type of a scenario where it's outside that typical age group and therefore your typical sort of potential condition that you're looking at. But, with the history there, and you start going, okay, well, let's go back to the patient, let's talk more about this, how are they presenting, and then building a little bit further. Okay, well, not appreciating being booted. And ain't that a classic sign? But then going, okay, well, let's revisit this. Let's put a change of management plan in. And I know Nick and I definitely surgically, and coming from the podiatry background that we've got, it's really a big part of what we do is exhaust the conservative, and then we'll look, okay, let's have a chat about surgery. And, a lot of the time of course I love surgery. And so I'll flag potential surgical options, and then I'll say, but let's not start there. And, I might say, we can look at a Morton's neurectomy, but let's take that back and let's actually start talking about, okay, well, this is what's actually happening, or what we think, given, 7 or so theories on how they start. But then going, okay, let's change this pressure redistribution. Let's potentially look at injection therapies. Let's look at laser therapies, reducing that swelling. Let's see what else we can put into place, and then check in at each point as we're going through that plan. And I think that's a really big part of it, going from there.
I was just going to say, I think it's an important point to note, though, and Dr. Chow, you might have something to add to this, that pain is a symptom that is experienced by the patient. There may be an underlying pathology, like an incredibly large Morton's neuroma or something like that, will continue to bring back that pain even if we are managing it very well. And so at some point we also have to use ongoing pain, chronic pain presentation to look for an underlying pathology and address that if needs be. So keeping in mind that this is sort of always almost a treadmill kind of exercise where we're running against the symptom to try and deal with the underlying cause. And sometimes it can be enough and we do just deal with the symptom, but other times it can be frustrating because as long as that pathology's there, we're going to be struggling to try and manage it. From your point of view, how frustrating does it get from time to time?
Loaded questions, here we go. You've seen it first. But we've been talking about, never do patients come through with one problem. And I think your specialty is the epitome of this.
Yeah, that's right.
Yeah, doing chronic pain is definitely take a special person to do it for sure. In fact, most of my patients, unfortunately, they all come with could be secondary or primary psychological symptoms to go with it, just because of where the chronic pain evolved. Anyone with chronic pain will probably understand this very well. That is very taxing for the energy, sleep quality is changed and all these things. So, what Nick said was completely correct. How the chronic pain could keep returning, and then the lack of understanding of it make it really more frustrating. And then some people have a very curative mindset about how I get rid of the problem. I never need to deal with it. Or maybe I just have this injection. I will never have to deal with it ever in my life. And that's probably not the right mindset. More about, all the whole day we're probably talking about how we want to have this biopsychosocial model, collaborative, multidisciplinary care. And this very important message I think we want to carry out is that managing a complex pain symptoms is not one person, just do one thing and they can manage it. It's almost like a team, right? Together, we work together, how we can manage together. Yeah. I hope I answered the question.
Good one.
Quite frustrating is what
Nick here with a quick answer. But and it is that, there's so much going on with a lot of these sort of patients. And, I'm really looking forward, and, hope everyone will be tuning in tomorrow when we've got Natalie Lazarowski on, who's our psychologist, and she is going to be talking about this sort of stuff. And, she's working with us at the moment to sort of start developing these resources for the practitioners, but also for the patients, because we start then, going into that bigger picture of, is it all in my head? And, and unfortunately, that's that medical approach to not understanding a lot of this, and people leaving it is in your head, when, okay, well, it's not in your head. There's a few things that are miswired and that are, causing a lot of hypersensitivity in the presence of, potential physical trauma, in the presence of previous trauma psychologically, like we're talking about. And, I've had some great chats, and I know Dave has as well, with regards to breaking down all these micro traumas, which have built up into this big psychological trauma that's now manifesting itself in a physical symptom. And that's not going to happen overnight. And, you know, some of the psychology approaches to this, and, you know, I could talk on this all day. It's fascinating stuff because, you know, like that biopsychosocial model, and we've talked a bit on it, you know, bringing in those social influences and, you know, who we've got at home to support.
Sorry to interrupt, but simply saying just because it's in your head does not mean you're making it up.
And that's
There's a
exactly
key
it.
difference there.
And it's breaking down those barriers. And, you know, I remember having a younger gentleman that was about sort of 26, 27, and he had really chronic foot pain post a fracture when he was in his teens, trained as a nurse, did his 3 years of nursing, did that for 2 years and left to be a baker because he couldn't stand on his feet anymore. And as a baker, he was swinging around on his chair. And he came in to me 10 plus years after his initial incident with a chronic pain syndrome, yet to be formally diagnosed, who had said to me after my consult and me saying, yeah, we're going to fix this. This is what we're going to do. Here's your treatment and management plan. And he's just said, thank you. No one's actually realised that this is something that's physical and that this is affecting me. And I sort of think, you know, such a shame and a missed opportunity in the health industry to put this, you know, young guy in a really good position. And so, you know, having these forums, I'm like, yeah, we're getting there. We're changing the face of healthcare, as I keep saying. You know, it's this is what it's all about, and linking people in. And I know, Chow, you're like, he said biopsychosocial when we were chatting before, and I'm like, oh, this is it. This is my jam, because you know we often forget it. We see the patient in front of us. We just want to focus on, oh, there's a physical thing here. And, you know, a lot of the time it is, you know, physio, podiatry, a lot of the time we're coming in, and definitely podiatric surgery, this bone is out of alignment and it needs to get back in alignment. A lot of the time it can be cut and dry, but not always. And often it's a bit of both. Yeah. Where are we going? Biopsychosocial. I think let's unpack that a little bit more, because I know Nick did a little bit there, but really putting people in the right environment and getting people back to work. I think physio is a big part of getting people back occupational as well. Tell me a little bit more, Mel. How do you do a sort of a return to work sort of plan and building their pain into that? Again, we talked about that pacing technique as well. I imagine that's a big part of it. What else have you got to say about that?
Well, I guess evidence shows that the sooner someone can return to work safely, the better the long-term outcome is. So I think for us, like what Chow was saying, is that there's that emotional kind of like it takes its toll on the patient if they're not at work and they're not seeing their friends and they don't have that daily routine. And then I think that just is like a flow-on effect, and then it kind of drives that pain response as well. So
that's it. And it builds into a physical, emotional, psychological, and financial.
Yeah.
And that's you know, a really big component of people saying, yeah, righto, doc, I realise that you want me to be off my foot, but I can't do that. I need to get back to work. How can you enable that?
Yeah.
And it's tough.
It really is. So we do a lot of pacing techniques. We'll kind of talk with the GP or the workplace, and I might do like a functional capacity assessment, and I'll be like, this is what this patient is capable of at this point in time. Let's trial this for 3 or 4 weeks, see how this goes. So we'll maybe reduce their lifting or their standing time, and then they might go back to work for 3 days, maybe 4 hours, something like that. And I might suggest, like, let's try Monday, Wednesday, Friday, so we have some nice rest days in between, and then we just build from there. So, and I think a lot of people struggle if they're the kind of the main source of income for the household. Then there can be other family stresses that kind of come with that, and it can be quite sad. So, and I think that's good when we know to kind of refer on, seek help, talk to other people about it. How else can we assist our patients to make sure that they're on the right path to getting better? Because it may start as an injury, but then a lot of things kind of flow on from that. So, and I think as physios, like once that door closes, and you guys are probably very much the same, like you build relationships, and I think we're a little bit different in that we'll see people every week. We see them twice a week sometimes, so we get to know them as a person and their families, and sometimes they feel, I guess, maybe more comfortable talking to us than, say, sometimes their GP or their psychologist or whoever else they're seeing. And I think it's just because we are that regular form of contact for them. So, yeah, it's definitely a bit of a juggling act for us to kind of know what's the right thing to say and when to refer on and just support them in every way we can. So, yeah.
Yeah, and these were the soft skills that Dave and I were talking about earlier as well, and it's so tricky, and everyone is different, and managing those expectations. But yeah, and particularly here on the south coast of New South Wales, GPs regionally and rural, they're coming in for their potential registrar rotations, and then they're rotating out, and broadly across healthcare, it can be really tricky to get that person that you're really happy and trusting with to be able to disclose that. And like we were talking earlier with Natalie, with reference to Natalie being that it's, about having those conversations and breaking it down. And, sometimes the podiatrist, doing the skin and nail care, it can almost be like the hairdresser that, you start unloading and say, oh, I've had this really, really crap week and this is it and blah. And it's about supporting them through that and, not necessarily telling them what to do, but it's more about, okay, well, what are you doing to that? And then get them thinking through those processes and, potentially referring off to the GP for, a mental health care plan if it's appropriate. Right. And knowing these options are out there is something that I'm really passionate about, because a lot of the patients that we see that may be doing this, they are at wit's end and they need that social support from, community health groups and, and GP and etc. And that's, building in preventing them from getting to the point where, they need to come see a pain specialist, potentially for, pharmacological management and, potentially for insertion of one of these pain devices. Or, like we were talking earlier, those quarterly directed sort of injections or as appropriate. Where we can decrease that burden generally is really good. But we're all gonna be pretty busy longer term, and so it's about, okay, well let's at some point we're going to realise, and we are at the moment, and I know Dave and I spoke about it earlier, is we don't have enough practitioners to go around in the community, and so we need to really start appropriately referring at these low levels to make sure when these things happen. So I think, yeah, it's a really good point there as well. Anyone else have something to add there?
I was probably just going to say about the conversations that we have with patients and the position that we get put in. Sometimes, particularly for new or junior practitioners, that kind of intimacy is not quite the right word, but that kind of conversation, relationship that we build with our patients is an intimidating one. A lot of people struggle. It doesn't have to be anything more than, as Kent said, just listening or being aware about other comments that they make about things happening in their lives and using your clinician's perspective to work that into a suggestion within their treatment plan, gently prodding them in the direction of a pain doctor, for example, or something like that. Yeah. So while it can be intimidating to do this, and I don't know if anyone was listening to my non-technical skills presentation, there are ways of systematising these things, and you shouldn't be intimidated by trying to talk to patients about this. Yes, it's not your primary role, but you are in a privileged position to be able to add something to this aspect of their treatment. And so being aware of it and leveraging that to achieve your goal, which is to overcome whatever specific pathology your technical skills allow you to. Don't let these softer areas get in the way of your treatment.
Yeah, and when you're not comfortable, I think it's about, and I definitely myself during my earlier days when I wasn't as confident, was just having a bit of a chat with the GP or putting it in, psychological distress due to recent father passing. They might not be in a position to advise the GP, or, they might be going in for a script, but it's really nice when the GP can say, oh, your podiatrist wrote to me and I understand that your father's passed out. How are you going with that? Yeah. And I just think that's a really powerful thing. That's a one-liner from yourself.
Excellent example, because their father passing has nothing to do with their foot pathology that they've come in with, but it does have to do with their perception of pain, their ability to follow the treatment plan, their ability to live their life, of which you're one aspect. So picking up on that and just letting them chat is very powerful, and you shouldn't leave that off your tool belt just because you think that it's not your area, if that makes sense.
Yeah, and
I'm actually quite impressed about today, it's just that everyone's having this understanding about how we see the person and the patient as a person. It's not just like, oh no, I'm only looking after the food and that's all I see. I think that's very important. No, that's correct. And actually a lot of our patients, probably just go and see a surgeon just for the back, or just go and see a particular person just for a certain thing. But the healthcare nowadays should change into this. Sure, we are expertise on this, but we also need to look at a person as a person. The how they implicated, like how their life being impacted by this condition should really take into account, because some treatment might be very effective for that condition, but might not be right for the person, and then we should really know about this.
yeah, and there's so much to look at there and unpack, and I think starting the conversation's a really big one, or and like we're sort of saying, if the patient does start the conversation, where we're going with that, but it is good to see, and I think there's definitely more of the recognition that we're part of that broad health team, and okay, well, what does a pain specialist do? What does a physiotherapist do? In contrast to a podiatrist, podiatric surgeon, and it's not more get out of my backyard, that's my turf. It's more, okay, well, at what point am I referring to this as well? And I suppose that's sort of where I'm wanting to just take these questions or the track here just for maybe another 5-10 minutes or so, because at what point we're very protective at podiatrists in our scope, Mel, and we think we can do it better, but where do we go? Okay, well, actually, I'm not fantastic with my hip strengthening. Where and going from there, but then to a bigger degree, it's then okay, well, pain specialty. At what point? Yes, we need to formalise this diagnosis of potential CRPS, and myself, I'm like, okay, I can see the signs. I'm pretty happy to put to the GP, signs consistent with CRPS, recommend formal diagnosis, potential referral for pain specialty review, and leave that up to the GP to further look at assessment and referral as appropriate, which is definitely the GP part of the equation there, being their overall health manager. But I suppose, Mel, where do you see yourselves in physiotherapy and that side of things as well? Because that's not something that I've really had a discussion around either. As far as, okay, physiotherapy, yep, you're seeing the signs. Are you similar to podiatry in that way and say, yep, signs consistent with these chronic pain syndromes, recognition and referral potentially needed?
I think it just depends. Like, we can treat CRPS. Like, it's not really my scope. I do know a little bit about it, and I think if I've seen a few cases over my career now, and I think I'm getting better at identifying it. And I guess I like to start some treatment, get them on a bit of a plan, and then if I do need more assistance, I will then refer back to the GP and be like, look, can we get a review with pain management, or whether it is maybe to go see a podiatrist to offload something if we're talking about like a foot or an ankle injury. I think I know in the Shahaba area, I think we're all quite supportive of each other. Yeah, I think we all...
We like to think so anyway.
Yeah, so, I am quite comfortable running next door and being like, hi, Ken. I tried to do it...
It's happened before.
Yeah, so, and we have good relationships with, fellow podiatrists as well, so... and I think that's just the best outcome for the patient at the end of the day, is that, like what we were saying before, we're a team. I think... Now that I'm a more experienced clinician, like I said before, I am honest with my patients, and I say, if I don't know something, we'll try this, and this, and then if this doesn't work, then I'm going to refer on. So, and I think that's the mistake you make as a fresh physio. You think you're
knowing your limits is important.
And you just think you're going to come out of uni and you're going to know everything and you're going to diagnose everything, and then that's not how it works in the real world. So, I think it's just, like you said, knowing your limits, knowing what your your strengths are, and then if you're not too confident in something else. And I know within my clinic as well, we have an open door policy, so our physios can chap on anyone's door if we have like a question. I had an MRI come through on like Thursday, and there was something on there that I'd never heard of before, and none of us had heard of it before, so that was okay.
That's good.
It was like safety in numbers, so
Yeah, you can all say to the patient, you have no idea what's happening.
yes. So and I think that just comes with experience as well, and just being honest and knowing within yourself when to refer on. So
That's
it.
And I think sort of when you started sort of speaking there, Mel, it was like, definitely put your plan in place and see how it's going, because that's a really important part. And it sort of made me again reflect on the fact, probably 60% of the patients that I see are in chronic pain, whether they're, syndrome or pain sort of medicine appropriate, because a lot of the patients that we see as podiatric surgeons, they've seen everyone else, and that's why they're coming to us. And then, they've been told, they've got a bunion, or they've got a hammer toe, or, they've got tarsal tunnel syndrome and need a tarsal tunnel release. And it's like, well, there's actually a few other, tools on my tool belt that we can use. And, I still haven't done a tarsal tunnel release in probably 3-4 years, because we're getting more effective at this conservative management through injection therapies, through our laser therapies, through our physiotherapy and appropriate rehabilitation. And I think that's a credit to all the professions and health industry generally around that as well. That breaking down sort of a lot of these barriers, and having that chat going and saying, I don't know what's on this MRI, and that's great when it is that everyone's in the same boat, because we've all been there. And so that's a really important part too. Do you have anything else to add there, Nick?
No, I agree completely. I think it's really important to know your limits and to lean into that idea of the extended team. Again, non-technical skills about team building and leadership, understanding your area and being able to create that shared mental model across time and space with different parties and everything. Usually utilising a GP in the middle is the way to achieve holistic treatment for patients who need holistic treatment. We're not talking here very much about non-complex patients. We're talking about patients with complex needs.
100%.
And it requires a complex solution.
Yeah, and that's it. And, I know we've only got a few minutes, and I'm definitely going to go over here. But because I want to see Dr. Chow, sort of, we're taking it full circle. We're steering away from stay in your lane type of an idea. But really, how do we, at what point do you sort of say, it's appropriate to refer to me? I'm a big one for practitioners getting on the phone and saying, Kent, I've got this patient, I've done X, Y, Z. They've got this condition that I've got on ultrasound, but they're giving me these symptoms that are not the same, or inconsistent with this diagnosis. What am I missing? What can I put into place? And I'll straight away be like, put this into place. You can do this at your clinic. Are you comfortable? If not, happy to help. Let's avoid surgery. But I suppose pain medicine is very different. And I suppose at what point are you like, okay, now this is in my lane?
Yeah. It's a very good question, Kent. Mainly because with pain medicine, relatively young among all the medicines, bit of it. Pain medicine used to be part of an anesthetic college. We'll give you a bit of history background. So slowly we develop an understanding a bit more how the pain is quite complex and a bit of mechanisms of it. And also pain probably is the only reason, or most majority reason for any part of the body that people go and see a doctor or a physio or podiatrist in that way. And when is a good time to refer a pain specialist? And that becomes that, how much we understand how the pain works. Like, sometimes you can clearly identify the nerve distribution of the pain, that you have done some injections therapy, or you have done, your doctor have tried some nerve medication, it doesn't seem to be moving anywhere, then become like, okay, maybe time to get a pain doctor to review. Or even a physio, like, seeing some kind of classical CRPS is one of them, or the pain that no matter how much rehabilitation you have done for maybe a year, just not getting the patient a bit better, then maybe your questions are, where is the pain coming from? How do we optimize the situation a bit better? Then that will be a good time to have a look, let the doctor to have a look as well. The pain medicine has evolved a lot, to be honest. That all the people who graduated from pain medicine have to learn how to dissect the mindset of a person, understanding how you interact, and how to locate underlying pathology of it. So sometimes even when you might be seeing a person that entire foot is sore. And that's like, even though you identify, that's right. You identify that, oh, you might have this and this problem, but how come your entire foot is sore? Then, there become a question like, oh, maybe have a degree of a central sensitization, and how do we minimize it through various medications, desensitization process, or even, maybe some injectable medications, or even like, is there the right doctor or right surgeon they refer to? The kind of situations all come to question.
And I think, that's a big part there, and, realising when it's, okay, well, this is not sticking to one structural area, whether it's a type of tissues, let's say the plantar fascia in this instance, when it is going to that full foot, and then saying, okay, well, there's no dermatome that's isolated, and, great when there is, and, that might be worth an appropriate injection, but when we're looking at sort of a grouping of dermatomes, or the whole lower leg, we're starting to think, okay, well, this is outside of, we might need some further input. And I think here as well is that we can't discount our GPs, specialists in their own right, and, really quite trained professionals to be able to start putting into a lot of this management into place and trialling it. And then on the failure of that, that's when, we're definitely bringing in pain management. And they might say, yeah, straight away, okay, well, this is something that I want further review from. And then, a lot of my patients, I sort of say, okay, well, we're looking at pain management, but I also want to rule out all of our rheumatological type concerns and our inflammatory concerns, because there's so much there. And, we start then bringing in, okay, well, lupus, for instance, is something that's going to be something there that, I see a little bit of, but it's not always a clear-cut sort of one that comes up. And there's a lot of those sort of soft tissue inflammatory conditions that, can be masked by a little bit of what we're seeing. But I think that's definitely a discussion for another day. I think I've been quite, I know, I'm like, oh, we've got to stop at some point. And because, I think there's so much information that we could go through. And, this is just a bit of a touch on pain and assessment. And I could talk about this for a couple of weeks, but we'll stop it for the moment.